So I'd like now to hand over to Helen Griffiths and Dimitri Gavriloff. They are both colleagues who are working with the Oxfordshire Hospitals NHS Trust. They'll introduce themselves far, far better than I will, I'm sure. So Dimitri, Helen, your turn.
So thanks everybody for coming from far and wide. I know you've travelled a long way, and we were really overwhelmed with the response to the conference. I'm not sure whether it was simply because it was free or whether you wanted to partake in our festive fairy lights today. But I know a lot of people have come a long way, and so we really do appreciate it. I'm Helen Griffiths. I'm a psychologist based at the Children's Hospital just here in Oxford, and I'll tell you a little bit more about that in a sec.
I'm Dimitri Gavriloff, another psychologist based in the team here at the Children's Hospital.
So Steve did all the sort of really highbrow, serious stuff about the legislation and all the important things that we need to be thinking about. But I want to tell you a little bit about how this project started, which is far less highbrow. It was many conversations in Pret, in the Children's Hospital, with a lot of my colleagues in OHS, so Helen here down the front, and Angela Ransby, who many of you will know, and some of my work with some of the hospital school staff, where we really started to agonise over some of the ways that these kids could be probably better supported by better multidisciplinary working. And that's really where the project began. But one of the things I've learned working on the project, and it's been a very steep learning curve, a real theme is that we just simply don't connect up enough with our colleagues from health, education, CAMS. There's so much out there. And so I thought, you know what, I'm going to start by telling you what I do and what service I work in, because it's likely that a lot of people don't know about this. So we're in children's psychological medicine. We're a multidisciplinary team. We've got psychiatry, family therapy, psychology, and we work with all of our colleagues in the medical teams at the Children's Hospital, so inpatient and outpatient, and we support children with health needs. That can be anything from a child has had their tonsils out and now they don't want to eat because they're worried about pain, to a child won't take their medicines and that's impacting on their medical treatment, to a child doesn't want to go back to school because they're worried about a change to their appearance, they don't know what to say. So you name it, and we deal with it. And we take a real holistic approach to supporting the child and the family, and that very much includes the impacts on education. And that's really where we started. Some casual conversations about what some of the gaps were, what some of the challenges were. And I'm going to share with you some really embarrassing stories, which I'm quite ashamed, and it's going off the online version of this when I come to edit it, because I'm not having it out there. It's too embarrassing. But really, I hope illustrates some of the practical barriers. You know, I haven't met many people that don't want to do this stuff better, but I have met a lot of people that just don't have the time, and that seems to be one of the biggest barriers. So what we decided to do, Angela and myself, sort of over many cups of coffee in Pret, we decided to collaborate. We decided to think about what would happen if we put a bit of resource into doing things with the proper time, and to work together more closely, to bring health and education more closely together, and to take the work that we do in children's psychological medicine and do it better, do it with more resource, have the time to go out to schools, have the time to meet with families and do this stuff really well. And how can we support our schools to take the guidance that Steve talked about and to think creatively about it? Nobody's got any more money for this stuff. A lot of this stuff doesn't attract any more money or resource. But actually, we really firmly believe, from talking to schools, meeting with people, there's so much creativity out there. People had come up with so many fantastic, low resource, low expense suggestions. And what we wanted to do was to widen the network and create opportunities like today where we could talk about it, share those ideas, and hopefully give hints and tips for managing things differently in schools. It's worth saying that what we didn't want to do was replace existing networks. I think it's fair to say that we've come across so many fantastic examples of joined up working. There's lots of teams out there doing different things. We've got our colleagues in CAMS talking later about some of the supports that they offer to school. Lots of great examples within our medical teams, the diabetes team, the pain team, all have fantastic links with schools. So this isn't to replace any of that, and I think it's fair to say we're certainly not the experts in any of this. But we hope that by having this extra resource for the life of the project, we can make a difference and support some of those systems. So Steve's talked about a lot of this. I'm not going to say a huge amount, but the research shows time and time again is what professionals say, what the research shows is that interprofessional communication is a real barrier to better supporting these kids. So I'm very lucky that I work on level LG1 of the Children's Hospital, and our paediatricians are just down the corridor in Community Peds and 2 floors up on level 2 if I need to ask any questions. So if I'm working on a plan with a young person about whether or not it's okay for them to go out at break time or what leisure activities they can take, I can run upstairs and ask my colleague and sit outside their room if I have to until they turn up after clinic. But actually it's so much more difficult for you guys. I don't know if anybody in this room has ever tried to get hold of me. I apologise. And whenever I ring you guys back, surprise, surprise, you're actually teaching. So it's an absolute nightmare. So it doesn't surprise me at all that this is often cited as a barrier. But what I've found clinically is that there's a huge variety in schools' confidence in managing these situations. And it's really no surprise if you haven't got the correct information and the adequate information to make decisions in your day-to-day management of these kids, how are you supposed to have the confidence to know what to do? And thinking of Steve's example of the kids with seizures, medically unexplained symptoms, perhaps, really, really difficult to know how to get it right in the school environment. So part of the project was thinking, how can we share the evidence bases that we work from in psychology in the Children's Hospital? How can we get that out there a little bit more? We're well aware that the need will far exceed anything we can provide in the project currently, but through events like this, we really hope that, that we can be part of sharing those tips. Why is this important? Steve's touched on it, and I've only got 5 minutes before handing over to Dimitri, so I'm not going to go through it. But we know that children with medical needs are far more vulnerable to mental health needs than healthy children. 6 times, up to 6 times more likely to have a mental health problem if you have a medical condition. We also know that the severity of the condition doesn't predict psychological adaptation. We see this in the Children's Hospital all the time. You'll have a family come in, the child's broke their finger, and it's the end of the world. And we'll have children who are experiencing cancer treatment, and they're incredibly resilient, and you think, how on earth do you do it? There are many other factors involved with psychological coping, and not just the severity of illness. We really need to work together to think about the best way to support these kids. We've touched on this already, but I love this slide because it kind of looks at the really wide variety of impacts of having a medical condition. It's not going to surprise you, but these things are really well researched. We know about the impact of less sleep on attention, concentration, mood. We know about the impact on looking different, feeling different, on self-esteem, depression, anxiety. And so what we wanted to do was really to put some resource into thinking, okay, how can we support our local schools with joining some of this stuff up? How can we knew from the Healthy Schools Alliance work that nationally the knowledge of some of these frameworks was low, and that schools who have a medical needs policy and who use individual healthcare plans routinely was low. So we thought, how can we take what is out there and support our schools to implement it? Like I say, we wanted to really build networks. We wanted to know what was out there, and we wanted to provide forums like today and like the training days that we've put on to showcase what is already there, and maybe just offer a space for our colleagues that are in also resourced stretch areas to have that forum. And what was really important to us, we've got 2 years, we finish at the end of 2019 at the moment. We wanted there to be a legacy. There's not much point in us doing a huge amount of individual work that then finishes, but actually children's psychological medicine will still be there, CAMS will still be there, and hopefully some of the learning that we'll take from some of these processes, like using IHPs really effectively, won't go away if the project does come to an end. So Dimitri's going to talk you through in a bit more detail what we've done so far, but we set up a partnership school programme. So we advertised in School News, for those of you in Oxfordshire who get that, a 3-day training programme for our schools, and we offered modular sessions on more in-depth issues that schools told us they would like more information on. So we pulled in other people like CAMS and so on to come and help us with that. And throughout the course of the year, we offered our schools access to the medical needs in reach team for consultation and training dependent on their needs. Here we are today, the conference, which snuck up on us. I can't believe that it's here. And a real key thing was that we had the funding to be able to support our schools to attend the training days. We're also working directly with Oxfordshire Hospital School. This is in its sort of setup phase right now. How can we add value from a psychology perspective into the assessment of children getting referred into OHS? How can we support OHS in the professional training that they put on? And how can we really strengthen the links between OHS and children's psychological medicine? Because there's a huge amount of commonality in referrals. And finally, again, in year 2, we'll be thinking about our medical teams. How can we do more work with them? Think about what is working well and what we can develop and what in psychology we can support. How can we make those links better and how can we be that sort of, what's the posh word, conduit? Is that right? Yes, for health and education. How can we run upstairs and get the questions that the school needs and create those pathways? And how can we demonstrate through excellent use of IHPs that this is really a tool that is of value, not just in physical health, but in mental health too? How can we use what we've already got to our advantage and in a less resource-intensive way to make a difference? So I'm going to hand over now to Dimitri, who's going to tell you a little bit more about our training days.
Thanks, Helen. So we were very lucky to be able to offer some really comprehensive training. This isn't the kind of thing that you get to roll out every day, and so we had lots of time to think very carefully about it and think about what people were asking for and what they need. We ran a 3-day program, so 3 periods of training that were done across the space of about 3 or 4 months, and they were there specifically to offer a kind of a really broad spectrum approach to helping people come on board with some of this stuff. We've then now condensed that to 1 day because we know that 3 days isn't something that we can do very easily for everyone. So we're working on producing a condensed version that we can then kind of roll out more broadly, and that we've evaluated as well. So it's part of what we're keen to do is to make sense of whether this is actually helpful for people in the first place. Because if it isn't, then we can revise things. So our training project content was really trying to think about setting the scene, helping people get a sense of the statutory guidance itself and introducing it to people. As Steve said earlier, the statutory guidance has been around for a long time. It's been around for 4 years now, and there's been many years previous to that when it's been in other shapes and forms available. So really we were offering people access to that in a kind of a more participatory way, I guess, and helping people come on board with it through introducing it by exploring it together, thinking about what it means practically. We looked at common mental health and physical health conditions. We're not training people to become clinicians, but we're helping to talk about this stuff openly and think about it, ask questions where they need asking, and do our best to kind of facilitate learning there. And to think about the impact of that on someone in school, so as Steve was saying, such as things like non-epileptic attack disorder, things like that, things that people might not be very familiar with. The second day was looking at actually putting things into practice and thinking about how it affects us as professionals too. So what the barriers might be, these are things that we've already talked about today, and coming back to some of these attitudes and beliefs that we might hold as professionals and how they kind of factor into things. We're psychologists after all, Helen and I, so very interested in that kind of thing. We also talked a lot about this key, kind of very ubiquitous finding in the literature, which is that there's a real deficit in interagency communication. So how do we better achieve effective communication between services, between professionals, to benefit the children that we work with? And we thought about the practicalities of writing an IHP. These are things that, in a very literal sense, get everyone on the same page. It's a very useful document, but it's not an EHCP, it's a different thing, and so there's confusion about what it means, how you do it, who needs to sign it off, and so on and so forth. So practically putting that into action was really helpful for us. And the last bit was really bringing everyone together on the last day to introduce each other, to have more of an idea of how this interagency communication would work and how it would be effective. So that was kind of where we ended up finishing. We also explored wider issues, things like gender identity and sleep in children and young people that weren't covered earlier. We had really great attendance. We can't talk about an attendance kind of conference like this. We can't sort of forget that this is busy teachers taking time out of their busy teaching schedules to come in and to do training. So we were lucky to be able to offer funding for people for cover, but we had really good attendance, and people were generally able to stick it out and attend each of the training days that we had. We had lots of representation from all three kind of areas of the primary sector, secondary sector, and special schools too. But we had what we might call, we're sort of preaching to the converted to a degree. We were preaching to people, we were talking to people who were on board with this kind of stuff and might not have necessarily nailed all the practicalities of it, but had certainly bought into the kind of the wider picture and were keen to kind of participate. But also we think of this in an interesting way too, as sort of early adopters really of something that we can then roll out more broadly and help sort of future cohorts come through and kind of do something similar, but a bit later down the line. We were aware that actually these whole day events that we were able to offer really helped increase attendance for people. So offering little trainings that sort of here and there are a little bit more tricky for people to fit in, and having a day they can block out and come and do things was much more helpful. But this is how it looked. We did it across, as I say, we're 3 days, but actually spaced across the first half of the year. And we had measures that we took at each of these time points. We were really trying to evaluate in again, a fairly broad sense, whether we were meeting our aims of increasing people's awareness of various key domains that we'd identified, and whether we were actually helping to increase people's confidence in being able to work with those key domains, key areas. And that's something we'll talk about in a moment. But what we did is we had measures that we delivered again at 3-month follow-up, and we'll do that again at 12-month follow-up with our partnership schools. We've got some of our partnership school attendees here in the room with us today. We're very lucky that they could join us. But it's an important part of evaluating whether this stuff is actually really helpful. And what we saw is, apologies for the sort of slightly complex lines here, but what you can see is that actually these key domains, looking at statutory, increasing awareness of statutory guidance, increasing awareness of medical needs in a broad sense, so mental health needs and physical health needs, increasing awareness of internal sources of support for people, so thinking about within the school, who do you go and see, who do you talk to, how do you access change, how do you talk to fellow colleagues about these kinds of things. External sources of support, so reaching out to CAMS, reaching out to community services, how does that happen? And another key element to it is thinking about your personal well-being. Steve touched upon this in his talk. It's an important thing that we can sometimes overlook. Working with this particular group of young people can be emotionally quite challenging for us as professionals, and it's an important thing to bear in mind in terms of how we approach it and kind of how it makes us act and respond. So those are the areas that we looked at, and true to form, we were very happy to see that there's a steady increase in the way in which people were able to kind of feel more aware, more confident in the knowledge that they were given. We did measures at before and after, which is why you get this sort of triangular effect, but generally the trend is up. And at follow-up, what we're really happy to see is that even after we finish the training, people are still feeling very confident. As their awareness is still kind of increasing, so there's extra learning going on. The confidence, again, is similar in picture. You sort of see people feeling generally more confident with what we talked about, which is really kind of one of the key things we're really interested in, so we're thrilled to see that. As an interesting little dip here in the personal well-being bit, this is the point at which we started talking about the heavy stuff, so talking about how it affects you emotionally, how it affects us as professionals in a kind of in a reflective sense. And maybe we hypothesized that might be little dip there because people were sort of taking time to sit and think, gosh, this is actually quite hard work at the end of the day, and it sometimes can be very frustrating not being able to get hold of the people you want to get hold of, but it can also be emotionally quite difficult to work with what are quite distressing stories sometimes, or quite difficult emotional content. But then again, the confidence is increased, and at follow-up, not only has it kind of been persistent, it's increased too. So we're thrilled to see that, and very happy. In terms of the effective communication, we were really looking at whether people who attended felt that they were communicating effectively with families and with services more broadly. And we saw again this nice trend towards people feeling, so this is before we started, after we'd finished the training and then at follow-up. And you can see that people feel broadly like they're doing things more effectively, which is again a really key part of what we were trying to get happening. The qualitative feedback we gathered from the semi-structured interviews we did at 3-month follow-up with all our attendees, and we've kind of grouped them. For any of those of you who are qualitative researchers, please excuse the fact that this hasn't been done in a truly scientific way, but we've kind of pooled things broadly. And we found that people generally felt that the course of training was very helpful. People were very encouraged by being able to access it and to come along to the training. They also found that, I think, they felt more firm in terms of their foundations for going forward. These were people who were already on board, broadly speaking, with the aims of the project, but they were feeling like they could get into the statutory guidance in a more, as I say, in a more accessible, practical way, and felt validated, I guess, in their existing use of IHPs and having a medical policy, rewriting them together with members of the team where necessary, talking to colleagues about it. And so that was important. It was also an opportunity for people to start thinking differently, an opportunity for people to kind of actually have a space to start being innovative with ideas. How do we put this into practice in school? What does that mean for things? We had people in one school who have now got gender-neutral toilets, so there's elements of this that are things that people wouldn't necessarily have space to think about elsewhere, and it's quite encouraging that people felt that they were able to do that through the use of the project. Adaptive PE is something that I think we're going to talk about a bit later too, but again, something that I hadn't thought about hugely, not being a sportsman myself, being a bit of a nerd instead, but bit of a nerd is putting it very mildly. But the reality is that these aren't things that we generally get to talk about, so having experts from the hospital school come in and talk to us about what that means practically was also very useful for people who attended. And again, that idea of communication, so thinking about how we share information internally, what does that mean? People have pupil profiles and they've got their registers and things. Well, what does that mean for how you share confidential information between colleagues? Does everyone need to know about all these different bits and pieces? Do we need to share that information with external agencies in the same way we would do with internal agencies? So thinking these things through in a helpful and practical way was really an important part of what people were able to take away. Particularly thinking about information sharing across NHS agencies and education agencies. We all get very worried about the term confidentiality, I think, and rightly so, because we want to protect it. But sometimes that might get in the way if we think about what it is that we want to achieve. And so it's about being safe and working within the system, but also achieving effective communication. The practical support that also we were able to offer was, I think, really well received. As part of the project, schools were able to have a direct kind of line to CPM, to the Children's Psychological Medicine Department, and to talk through cases anonymously in a safe way that meant that they could ask questions that they probably didn't get a chance to do elsewhere. And the feedback we got from teachers was that was really helpful for them. They were able to have those conversations in a very, in a kind of very honest way. We don't often like asking questions where we feel on the back foot, and so having a sort of a safe space to do that is great. And there was a really interesting opportunity for people to have peer reflection and peer kind of networking. So schools coming together and saying, you know what, you're nearby, I'm nearby, why don't we get together and do things differently? So what did we learn? Well, we knew that actually the schools are generally aware of the DFE guidance. I think it's, schools are pretty good at being aware of these kinds of things. It's about how they kind of feel able to put things into practice. And actually the scope of the use is pretty narrow. So it's, when is medication administered and who administers it? Where's the anaphylaxis pen or the EpiPen and that kind of stuff? IHPs are much broader than that. They're not just sort of tick box things. They're there to enable someone. And as I say, if we're all on the same page, literally, then we all have the same sheet to sing on. Far too many analogies there, but it's an important part of what we're doing is helping people feel they can practically kind of engage with it. We struggled a bit with time and with the resource, and I guess people weren't always clear about what was available locally. So part of what we were able to do was to help with the networking at the last part of the training. But it was part of our shared aims at the beginning to really bring agencies together. So that was useful for us and for the attendees. We were very keen to help, and I guess there is a degree to which that sort of limited information in schools about a child's healthcare situation or their condition can be kind of prohibitive in their effective support in schools, and navigating some of that was tricky. We talked about the confidentiality issues earlier, but it's something that we found that people generally fed back was difficult too. We have a strength in motivation, I'm sure, to carry on, and the collaborations I think that have been fostered have been really important. We know that the IHPs aren't used broadly across the UK, and go back to that piece of research that Steve talked about earlier from the Health and Schools Alliance, that actually vast majority of schools might not be using IHPs, or they might call them something else, but actually there's lots of room to carry on with that. I'm getting the sign for hurry up and stop talking. They also they're very wide-ranging in scope, but in practice, again, they seem to be quite narrow. And there's limited awareness of these things outside of education. We found it a really helpful tool for managing these complex conditions. And I think one of the big things was enabling this interagency communication again, so having people feel like they could call up the pediatrician or could call up a nursing specialist who can kind of advise. It's helped with safeguarding for a number of cases that we've discussed as a group, and we're all on the same page. There's no ambiguity. We're going to talk more about IHPs a bit later and about how things go forward in the next year. But broadly speaking, it was a helpful experience for us all, and I think we're very grateful for the opportunity to be able to do it. 3 seconds left. All right. Thank you very much.
I'm going to jump in just at the end and sort of just wanted to say, you hopefully are all thinking, that sounds great, but it's happened, and I didn't get to go on it. If you stick around till the end, we will tell you about what our plans are for year 2. So we are hoping to take on board a second cohort of local partnership schools. And what we really want to do is condense the training down into a one-day programme that our colleagues across the country, so we've already got some interest for other paediatric psychologists and other hospital schools, and our aim is that we further evaluate the training and roll it out in its most helpful components. So stick around till the end of the day. This is my little trick to get you to stay. If you absolutely have to go, come and find me at lunch and I will sneak you a bit of info before you head off. So thank you.